Good afternoon and a very warm welcome to NITRD-CTD-NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to welcome our DDG Sir, Dr. R.P. Joshi, Directors and team from NIRT, NTIs, STOs, Directors of STDCs, Faculty of Medical Colleges, District TB Officers, Medical Officers, and all the participants who are attending today's clinic. Introducing the faculty from NITRD, I am Dr. Saroj Meena, pulmonologist at NITRD, and on my right is Dr. Rupa Singla sir, consultant in Department of TB and Respiratory Disease. Dr. Neeta ma'am, who used to moderate this eco clinic session, today she is out of station due to some work. Now I request Dr. Singla sir to give his introductory remarks.
Thank you, Dr. Saroj. A very good afternoon to all of you. DDG-TB, Dr. R.P. Joshi, directors of various national institutes, the STOs, DTOs, medical officers, faculty of the medical colleges, the students and all the doctors and the students who are attending this clinic today. Welcome you all for this national level difficult to treat TB clinic. As you all know, for last few months, we have adopted a policy that turn by turn, various states will be presenting one case in the National Difficult to Treat TB Clinic and we'll be discussing the case. DDG-TB Dr. R.P. Joshi had suggested, which is a very good suggestion and we have adopted it, that we need to raise different issues in this. Today case, as you will see, the primarily we are focusing on the issue of non-compliance to treatment and also the poor drug treatment regimen being made by the various doctors. And this includes the government doctors as well as the private doctors, mainly the private doctors. So what happens in case you give a wrong regimen and in case you do not ensure the compliance of the patient to the treatment, then it can lead to augmentation of resistance. A simple case becomes very difficult. And let me remind all of you that it is the duty of the program personnel to ensure that patients are taking the medicine. And that's why this concept of directly observed treatment is there. And I'm sure you're all aware about our Managed TB India app. So this app is mobile-based app. In case you use this app and you feed the correct patient's clinical data, the laboratory data, the other blood test, it suggests you what is the ideal regimen for this patient, including the dosages also. And it has been approved by the Central TB Division, Ministry of Health, for use by all our colleagues. So please download this from the App Store. And it is free of cost and you can start using it and give your feedback also about this app. With these few words, I welcome again Dr. R.P. Joshi, the DDG-TB, and may I request him now to enlighten the house with his kind words. Dr. Joshi, please.
Thank you, Dr. Singla sir. Thank you, madam. Good morning all. Welcome to this difficult to treat TB clinic at national level. I first take this opportunity to congratulate all the team, Dr. Singla and team involved in this very, very important and useful endeavor. And it is really appreciable that they are able to do it and sustain it. More than 100 national level TB clinics have already happened. And I also take this opportunity to thank all the faculty members who are actively participating and all the participants. We usually have around 200 participants or more in each clinic. That is a sort of certificate to the team that it is worth it and it is useful. Having said that, I requested Dr. Singla sir to not only the difficult to treat TB clinic, which is important to clinicians and academicians to stimulate thinking about difficult cases, but also take the practical issues and see how it can be resolved so that our whole NTP family of doctors can get an understanding of the best practices and how to manage the practical issues. Because when we face the patient, there are issues beyond the medically difficult part. They are difficult from other aspects like behavior or other things. So I'm grateful to Dr. Singla and team for adding this component also. So on behalf of Central TB Division, I welcome all of you and a special thanks to the faculty who are going to present today and looking forward to learning experience again. Thank you all.
Thank you, sir. Thank you, sir. Moving on today's case presentation. In the current series, as sir told, that the states are being invited by the rotation to share a difficult case from their state eco sessions, giving us all an opportunity to learn from their experience. In these sessions, we have an expert from the state and a national expert. Today's session is from the state of Uttar Pradesh. The presenter is Dr. Amitav Das Shukla, HOD, Department of Respiratory Medicine, Motilal Nehru Medical College, Prayagraj, UP. Today's state expert is Dr. Rishi Kumar Saxena, who is the Deputy STO and Joint Director, TB and Chest, UP. Today's national expert is Dr. Vishal Chopra, Professor and Head, Department of Pulmonary Medicine, GMC, Patiala. A very warm welcome to the team. Now I'll request Dr. Shukla, sir, for the case presentations. Over to you, Dr. Shukla.
And before that, Dr. Shukla, I want to inform everyone that we feel proud to announce that Dr. Amitav Shukla worked with us in our institute as senior resident. And now he is heading the department of a reputed medical college. So, Dr. Shukla, please.
Thank you, sir. Thanks for your blessing, sir.
Dr. Shukla, you will be presenting the slide from your side, or you want us to present this slide? You are the co-host, so you can do the slide share and present.
That's what I'm trying to do, sir.
Okay. If any difficulty, we have your presentation, and we can do it from our end also. So that is your choice, whatever you prefer.
So are the slides visible, sir?
Yes, they're visible. You can make it on the slideshow.
Yes, sir.
Now, yes. Perfectly.
So today I am going to present this case of difficult TB case. It was presented to our nodal DRTB center in December 2022. And since then, the patient is managed by us and followed by us also. He was a 32-year male police trainee resident of Mirapur, Prayagraj. He came to our department on 15 December 2022 with chief complaints of cough with expectoration for 4 years, loss of weight and appetite for 4 years, fever off and on for 4 years. All the symptoms suggestive of tuberculosis. He was a non-diabetic, non-HIV. Vital parameters were within normal limits. In past history of ATT, we see that he was initially treated for drug-sensitive TB regimen from 22nd of February 19 on NTEP DSTB regimen based on clinical and radiological findings. It was not supported by a microbiological evidence. Treatment for entire duration was not regular. Patient had to travel frequently for his job requirements of police. And as expected, after 6 months of DSTB regimen, on 6th of August, he was found to be sputum positive. So it is quite evident that he failed on this DSTB regimen. And on 19th of August 2019, CBNAT was done and found to be rifampicin resistant. Now, this is the radiological picture. When we see that in 6 months, there is a clear radiological deterioration in this case. If we go for the past history of DRTB, initially it was DSTB. Now, when he was started DRTB regimen after observing that rifampicin was resistant on CBNAT, he was started on the shorter regimen from September 2019 under DRTB with kanamycin, levofloxacin, etheramide, ethambutol, paracetamide, high-dose isoniazid, and clofazimine, the standard shorter regimen. First-line LPA report, unfortunately, is not traceable. But second-line LPA that was sent in September and received in November 2019 shows that fluoroquinolone was resistant. And on 27th of November, the regimen of this DRTB was modified. Levofloxacin was replaced by high-dose moxifloxacin and high-dose isoniazid was removed. Rationale for this modification is not very clear. Follow-up sputum culture, although it was negative in December 2019, we see that this was the regimen on which, this was the X-ray on which the shorter regimen was modified. Patient took this modified regimen till February 2020 for about 6 months. Again, it was stopped due to job requirements of police. He had to travel frequently. He could not remain committed to a particular center. And moreover, there was COVID pandemic disruptions also that started in March 2020, we know. And from subsequently in June 2020, patient started taking treatment from private setup in Kanpur, because in government setup, he was supposed to visit all the time. He was supposed to remain in the follow-up. So these were the inconveniences that were faced by the patient, and he preferred for a private practitioner treatment at Kanpur from June 2020. This was the X-ray where the private practitioner of Kanpur started the treatment. Although gene expert again revealed rifampicin resistant, but the regimen given to this patient was not very appropriate in my opinion. Ethionamide, clofazimine, pyrazinamide, and ethambutol. After 3 months in September 2020, ethambutol was stopped and other drugs continued till November 2020. After 4 months of the treatment in December 2020, he developed psychotic symptoms. He had restlessness, hallucinations, aggression. He consulted a psychiatrist and he was diagnosed as acute psychosis with depression. He was prescribed treatment for this psychotic manifestations, including haloperidol, clonazepam, propranolol, olanzapine, and fluoxetine. He was also diagnosed with hypothyroidism, and he was put on thyroxine, 125 micrograms daily. Now, it is again a speculation that whether it was a drug-induced psychosis, whether it was the circumstances-induced psychosis, or whether it was a hypothyroidism-induced psychosis. Anyway, somehow the patient recovered with that. If we look at this X-ray, this was the X-ray where the patient again changed his doctor. And in January 2021, he shifted to Lucknow to another private practitioner, and I don't know why he started RAGZ. Although there are 2 previous genotypic evidence to say that patient was rifampicin resistant. There was also a second-line LPA report which says that patient was fluoroquinolone resistant. But anyhow, the patient was started on RAGZ regimen, 4-drug standard regimen given for DSTB. But in March 2021, again ethambutol was withdrawn. The reason for this withdrawal, not very clear. In July 2021, again the regimen changed. Isoniazid, ethambutol, ethonamide, streptomycin. X-rays of this is not available. In January 22, again regimen changed to rifampicin, ethambutol. In March 22, rifampicin, ethambutol, ethonamide, injection amikacin. And in June 2022, again regimen changed, ethambutol, ethonamide, ufloxacin. And in August 22, they kept changing. And this all continued till October 2022. Now, if we see at the sequential X-rays, we see that this is the X-ray where ethambutol was withdrawn. This was the X-ray where the regimen of rifampicin and ethambutol was changed and additional drug of ethionamide and amikacin was started. Somewhere we see the response, and again we see that relapse is there. On this X-ray in June 2022, rifampicin, amikacin were withdrawn, but ufloxacin was added. And in August 2022, ufloxacin was replaced by clofazimine, and amikacin was added. And the regimen changed to ethambutol, ethonamide, clofazimine, and amikacin. It continued till October 2022. We see that whoever was the private practitioner in Lucknow, he kept experimenting with this patient, and without any microbiological rationale, without any, I don't find any rationale in that. Finally, the patient on 1st of November 2022, he underwent a phenotypic culture and drug susceptibility testing at Lucknow only, probably at the advice of some other practitioner. And we see that all these drugs, streptomycin, isoniazid, rifampicin, ethambutol, pyrazinamide, kanamycin, they were all resistant. The only sensitivity was for ethanamide and PAS. Fluoroquinolones were also resistant. Capreomycin, amikacin were resistant. With this, patient presented to us on 15 December 2022. This was the report with which the patient presented to us. We got his X-ray done, and again we see that initially some of the X-rays did show there was a resolution in the lesion on the left side, but here we see that left side lesion is again reappearing. We started on a DRTB regimen based on DST results and the previous history of the patient, previous history of the drug usage. And we started the patient on modified all-oral longer regimen, which included linezolid, cycloserine, bedaquiline, delamanid, PAS, and pyridoxine. One thing more we did, that we gave PAS in divided doses, 6 gram BD according to body weight. Clofazimine was replaced by PAS, and sputum was set for whole genome sequencing. This was after 1 month of treatment. Treatment strategy that we followed, that linezolid were given because he did not take previously. Moxifloxacin or levofloxacin were not given based on the DST and second line LPA. Moreover, he also had taken high dose of moxifloxacin for prolonged period. Hence, fluoroquinolone were replaced by delamanid. Bedaquiline was given. Clofazimine was not given because it was already taken for more than 2 to 3 months. It was replaced by PAS. We wanted to avoid cycloserine, citing the history of psychosis, but the benefit of using this drug was more than the perceived risk of adverse effects, because we are not very sure that what was the reason of psychotic symptoms that he developed at that time. Cycloserine was given, but a psychiatrist was consulted, and they said that patient could be started on cycloserine with close monitoring, weekly clinical monitoring. Psychiatric drugs given were clonazepam, melatonin, propranolol, and an anticholinergic, trihexyphenidyl. He is also improving from his psychotic symptoms like improvement in sleep quality, increase in appetite, etc. Now, what was our apprehension? That if the report of whole genome sequencing does not correspond with our current regimen, what options are we left with? This was the whole genome sequencing report. Although it does not correspond completely with the phenotypic culture report, but then also we see that the drugs that we used, patient was sensitive to them. Linezolid, bedaquiline, clofazimine, delamanid, PAS, all these drugs that we were using, patient was sensitive to these drugs. This was the whole genome sequencing report that we received. Currently, this is the chest X-ray. Patient is on regimen of linezolid, cycloserine, PAS, pyridoxine, whereas bedaquiline and delamanid were stopped on 1st of June 2023 as per the guidelines. Follow-up sputum culture of this patient on March 2023 was negative. Repeat sputum culture done on May 2023 was also negative. Patient has gained weight around 1.5 kg in last 9 months after starting the treatment. And there is improvement in terms of clinical, radiological, and microbiological assessment of the patient. So now we can say that we are on the right track and patient is satisfactorily improving. With this, I thank you all for a patient listening. And now we are open for discussion of this case.
Thank you so much, Dr. Amitabh. It was a wonderful presentation. And let me summarize the case to all those who have joined late in the session. So basically, patient was a police trainee and he was diagnosed with TB in February 2019. At that time, the smear was negative, but the patient took it irregularly. So at the 6th month, which completed in August 19, patient's sputum became positive. He was declared as failure. So CBNet was done at that time, and it came out to be resistance to rifampicin. So in September 2019, patient was given shorter injectable based regimen, and LPA was sent in September, which was reported. The report came in November. Quite late reporting of LPA was sent in September, and the report shows FQ resistant and SLI sensitive. So patient from shorter MDR regimen, there was little modification was done. Levo was replaced with moxifloxacin high dose, and INH was removed. So patient, the culture was done in December 2019, which came out to be negative. But unfortunately, after 6 months of the treatment, patient defaulted in February 2020. And thereafter, he was in June 2020, he went to the private practitioner where CBNet was again done, which again shows RIF resistance. And he was given private treatment with ethionamide, clofazimine, pyrazinamide, and ethambutol. There was no rationale behind the treatment. And after a few months, ethambutol was introduced. So from June 2020 till December 2022, patient was given went to multiple private practitioners, was given multiple regimens which were not rational regimens as per the guidelines and as per the treatment for this patient. So in November 2022, patient went to visited Dr. Amitabh and with the DST reports, which shows resistance to injectables, streptomycin, INH, rifampicin, ethambutol, PJD, and clindamycin. From December 2022, patient was started on modified all oral longer regimen, which included linezolid, cycloserine, bedaquiline, delaminate, and PAS. Patient shows clinical, microbiological, and radiological improvement with this regimen. Bedaquiline and delaminate has been stopped after 6 months of start of the treatment, maybe after seeing the culture negative reports. So now the house is open for discussion. Any questions from the audience? Any DTOs, medical officers, any queries from this question, any learning from the case? It was a quite mismanaged case throughout for last 2 years.
Hello.
So,
Hello. Hello.
yes.
Hello.
Yes.
Hello.
Yes, sir. Yes, Dr. Lokinder.
Yeah. Dr. Amitabh, you presented very well. Well managed by you.
Thank you, sir. Thank you, sir.
But if you can show me the X-ray before you started the treatment and current X-ray. X-ray when you started the treatment and you show the current X-ray. I want to compare that.
So the serial X-rays, they have shown improvement.
My concern is the current X-ray shows the left upper lobe, right upper lobe is slightly not clear. And previous X-rays, I may be wrong, but previous X-ray, the upper lobe, right upper lobe was slightly clear, but current X-ray shows the upper lobe is more involved than the previous X-ray. I just want to clear.
Yes, sir. Dr. Amitabh, can you please share your slides again?
Yes, sure, ma'am. Sure. Thank you.
You got my question, Amitabh?
Yes, sir. Yes, sir.
I think see, this is the upper lobe somehow spare, but current X-ray, now you can show the current.
Sir, this was the X-ray with which we started our treatment. Is it visible, sir?
Yeah, I can see.
Now, this was the X-ray with which we started, sir. And now I'm going to show you the X-ray which is at present September. This is the X-ray of September.
Yeah, this if you can see, the right upper lobe is more homogeneous than the previous X-ray. What is the meaning?
Yes, sir, it is more. It is appearing to be more homogeneous, but if you see that the trachea is also shifted to the same side, so
Yeah, that's
probably
why.
this homogeneity is due to undergoing fibrosis, sir. Probably.
But that much of fibrosis, because previous X-ray does not involve that much of lesion. But now,
जी सर सरायकला से बोल रहे हैं सर।
hello,
हेलो।
hello.
हाँ जी सर सरायकला से बोल रहे हैं सर।
So, Amitabh, do you think this is the fibrotic lesion?
Sir, if this X-ray you see of this was the treatment. This was the X-ray before we started the treatment.
Here you can see the upper lobe, right upper lobe, slightly better than current X.
Sir, yes, it is there, sir. It
Trachea on the
is,
same. Trachea is also not heavy toward the upper side.
sir, you are correct, but it is somewhat an expiratory X-ray, sir.
Okay, you can check it again.
So it is an expiratory X-ray and it has got a heterogeneous opacity in the right upper zone. And if we see this last X-ray,
It seems to be more dense.
it is, yes, sir, I agree it is more dense, but I think that it is probably due to fibrosis, and moreover, trachea is also more pulled up as compared to the previous X-ray, sir.
So it would be better you rule out that this is a fibrosis. Then it will be better.
May I come in?
Yes, sir.
Amitabh,
Sir.
first I must compliment you for a very good presentation because I have to leave. I am my flight, so I just say 2-3 lines as a comment.
Sir.
And one thing, what Lokendra was saying, that when you compare the X-ray, we have always taught that two identical X-rays should be compared. Now the X-ray what Amitabh you have showed, in which there is something on the right side, and it was rotation was also there, what I saw, and film was expiratory. So it is very difficult to compare. That's a very small point. We have recently, have written a book on chest X-ray, with which we have dealt everything in detail. It is into volume. The second point I wanted to raise, since the Deputy STO of State of Uttar Pradesh is here, and other DTOs must be there, to see what is the level of education among private practitioners. And I have always been of opinion that education, it means somewhere we have failed not to educate them. I don't know what level of, I also don't want to know, because this will be not legal and ethical. But then what is message is very clear. How this patient was treated initially for 2-3 years was something very bad, and that clearly tells that level of education among our doctors, especially in the private sector, is very, very low. And I always say, I'm of opinion, even my boss used to say these words, that education can change everything. So I would request, Rishi is here, I can see his face. Please concentrate. I'm saying it for last so many years, since this case belonged to Uttar Pradesh and belonged to Lucknow, and belonged to Lucknow also. So I'm very sorry. I think all the responsibility, because being a very senior chest physician, teacher of most of the teachers in the state of Uttar Pradesh, so I take blame on me, and then same time I advise the STO, Deputy STO, and other DTOs that please make sure that regular CMEs are happening. It is not that CME should happen. CME should be attended by the people who are treating the patient. What I have seen in recent year, CME is being done, but attendance is sometimes very poor. And sometimes those doctors who really need to be educated, they are not there. So probably we have to have some focus CMEs, especially in well-being practice. Since I'm sorry, I will leave early because my flight is there. So I'm going to Bangalore to attend the NTF meeting. So that's my comment.
Sir, just a point, sir. आप ही का सर सिखाया हुआ एक point है कि जो ये all these practitioners who were there in Kanpur and Lucknow, उनकी qualification sir नहीं पता है, that what was their level of qualification or what was their level of experience. And as per whatever is being seen, sir, it appears that they were not adequately trained for handling such patients.
Definitely. I agree with you.
Sir.
Thank you,
Now
Dr.
you are a professor. Now you are professor, and many of the IC Vishal Chopra is also here. So just
sir, आपका आशीर्वाद है, sir.
my final advice before I leave, because I leave, that please spend some time on education, and especially in the private sector. Thank you very much. Thank you,
Rajendra sir, and for your inputs. Now I'll take questions from the audience. Dr. Suman's iPhone. Yes, ma'am.
Good afternoon, ma'am. This is Dr. Suman, DTO Bhiwani, ma'am. So that's why this case is very nice presentation. And these kind of things, the irregular, irrational regimes and doses we encounter in nowadays. That's the point that sir has highlighted. I was also I want to point out this, and this is because sir, when we organize CME as a DTO, only the chest physician and TB specialist they do come. The other specialists they don't come, but they do treat the patients. So we have mentioned the law also. The ministry has got TB notification law also there, standard of TB care also there, but people don't follow that. So I think we should implement some laws like ultrasound PNDT Act, so that the TB patients should be treated carefully and logically, sir. That's why my point, sir. And now they have removed the TB part in the TB and respiratory part from UG curriculum also. And if this follows, then we will encounter such cases more and more. And we will have to treat by difficult to treat TB cases in such cases, sir.
Thank you so much. Dr. Sainath.
Hello, madam.
Yes, you have a question.
Hello.
Hello.
Am I
Yes,
audible,
sir.
madam?
Yes, sir. Please.
I wholeheartedly congratulate Amitabh sir for his beautiful presentation, and also to Rajendra Prasad sir for his elderly words. So I was very, very dumbfounded when he told that I want to take blame on me because not educating the people in my own state. So this is a common thing, sir, which we have seen. We are NTB by 2025. I feel sorry, even in my state, even Mysore, the regimen they put, even the pulmonologist or the so-called physician is so erratic. And afterwards, without proper diagnosis or without treatment details, they are
we will discuss more in detail about the rational regimen. We'll have
as Singla sir has told many times, radiologically improvement is depends on the lung destruction which was there before that surgery or at the start of the treatment. So we are bound to have some this one, sir, lung destruction, fibrosis, cavitation, or so-called everything. But the only thing is the patient is responding. So I wholeheartedly congratulate the team for their effort. Thank you, sir.
Thank you, sir. So we have questions in the chat box. Dr. Amita, please help me to answer those questions. Some are related to the history part. What about his family? Any contact developed? It's being asked by Dr. Vinod. Dr. Amita?
Yes, ma'am. Yes.
So what about his family members?
The family members are apparently healthy.
Okay, none of them developed the disease?
No, ma'am. No.
Okay, so any tapering of lineage already has been done during the regime which you have started from December?
Any?
Tapering of lineage
yes,
already?
it has been reduced to 300 milligram OD.
Okay. So, I think no FQ resistance was detected, right? There was one question, no information about the FQ resistance.
Yes.
Follow-up cultures, they are coming out to be negative. March, May, they are negative. Am I right?
Yes. March and May both are negative.
And you have screened the family members. They again a repeat question.
Screening has not been done, but yes, clinically it has been asked that is anybody suffering from similar illness?
Okay.
Or is anybody suffering from a predisposing conditions like diabetes or HIV? So the reports, the answers are negative.
Okay. So Dr. Vijay Chavan, he's asking, the current regimen has passed. Yes, it has passed. The current regimen, the CP
Yes,
phase.
it has passed. It has got 6 milligram, 6 gram BD in divided doses. We are giving it.
Okay. Okay, so Dr. Ankur, he's asking which report should be preferred among WGS and phenotypic DST.
In all these states.
This is a
Request the state expert to answer this question.
Madam, since we don't have any clue from the guidelines from the government of India regarding WGS, and it has to be implemented at a very large scale, so we prefer to do the cultures or follow cultures which are still considered the gold standard. And on the basis of this, we give the follow-up and the treatment depending upon the reports of the culture. So at present, we are still, we have to follow the Central TB Division guidelines, that still, though it hasn't been mentioned in the PMDT 22-21 guidelines, some part that it is an introductory part is there of WGS, but still it has to be implemented on a very large scale, ma'am. And the cost of it is very high, around about 100 crores will be needed if we have to mention such type of labs, as I've been informed, madam.
Okay.
So just for the information of the House, Dr. Rishi has mentioned very correctly that as of today, the WGS reports in our country have not been standardized. So as of today, the Central TB Division has not implemented a policy where we can treat the patient based on WGS reports. So once it comes to the clinical decision of treating the patient, it has to be the midget culture and DST as of today. And once the WGS has been standardized and we have the guidelines issued by the Central TB Division, by the experts, then only we should take clinical decisions based on the WGS. Only issue is that in private sector, many people are getting it done and patients come to us with reports. Sometimes we are cornered, we don't have midget culture DST report with us, then we can just take the help of these reports in taking a decision. But otherwise, once we have both the reports, always rely on the midget culture and DST report. Thank you.
Thank you, sir. There's another question from Dr. Jyoti Mandavi. She's asking why the shorter regimen was modified and not shifted to longer regimen. Yes, there was some lacune in this. The patient should have been shifted to the longer regimen at that time only. We will be discussing it in the discussion session in detail.
We can even discuss now also. Any thought by the state TB expert or the national expert, Dr. Vishal or Dr. Rishi on this? This is an important question which has been raised.
Sir, it is in my slide also, sir. This question which has been raised, it is in my slide also. Because I have, with what these slides have been showing, it is all evidence-based. What has to be done, what were the pros and cons of the case. And if these would have been done, then such type of cases cannot arise in a later part of the year. So okay. It is a very good question, madam. And it is evidence-based, because I have also mentioned some of the clips also of the guidelines also in that particular lines.
So if that is so, Dr. Rishi, can we have your, sir, can we allow Dr. Rishi to have his slides then?
Yes, sir. Yes, sir.
Sure, sir. Thank you, sir. Just a minute, sir. Stop share. Share screen. And stop share. Share. So it is not just a minute. Hey, catch and slide show current slide. Now this is the same what I will be doing, what slides have been shown, and in that slides also I will be trying to think what as a NTP staff and as a clinician and as a private practitioner who is untrained, what happens if such type of cases go there. So what were the pros and cons of the case? This is I will be sharing here. Now this is the same history. A 32-year-old man which has a history of cough, loss of weight, loss of appetite for 3.5 years, and fever of around 4 years. And he was non-diabetic in HIV. Now, the past history shows that based on the clinically based findings, he was given DSTB treatment. But because of the lack of proper counseling and the follow-ups and patient had to frequently go in his of job. He did not consult. He was not given proper counseling regarding adherence. And if initial counseling would have been done regarding pura course pakka ilaj from wherever he goes, as per his job requirement, he would have cured then and there only. But as a result of this, of irregularity, patient developed after 6 months sputum 2+ and also became rifampicin resistant. Sorry, just a minute. So my slide is.
So Rishi, your slides are very well visible. So
Yes, sir. Yes, sir. Now here, as you see, regarding X-ray of February and after 6 months in September, there is an increased homogeneous opacities in the left mid zone and also complete least homogeneous opacity in the right upper zone as compared to the February X-ray. Now, as it has been mentioned that in past history, shorter regimen was started. Now, this kanamycin, as per 2019 guidelines, these are the regimen of the short regimen. But on September 27th, second line LPA showed FQ resistant and SLI sensitive. Now, but the treatment of shorter regimen was modified after 2 months of delay. And in the meantime, patient was taking the same treatment. But it has been clearly mentioned in PMDT 19 and 21 guidelines also that if there is any replacement, start or longer regimen. See, this is a 2019 guidelines also where it is clearly mentioned that if there is a need for stopping, replacing any drug, stop the regimen and evaluate the patient to switch to all over longer regimen. However, the new regimen, the levoflox was changed to moxiflox high dose and isoniazid was removed. LPA first report, as Dr. Amitabh has also shown, that first line report is not available. However, the sputum culture was negative in December 19. Now again, because of the lack of counseling and smear examination, patient stopped modified shorter regimen for DRTB himself from 27 August after taking 6 months of treatment. If it had been done immediately after 3 months, patient would have been switched over to long regimen. Remember, it was before the lockdown. The lockdown started in March 20. Patient said it was due to job requirements of police and COVID disruptions. Patient went helpless and he went to a private practitioner in June 2020. Now, though there were no major changes in X-ray from November to June, as you are seeing, but only 19 to 20, I would say 19-20 का अंतर था, बहुत ज़्यादा changes नहीं थे. But patient went to a private practitioner who was untrained, and this is all he did. That he did the permutation and combinations of all types of drugs, like Dr. Amitabh has said, experimenting the drugs. Instead of starting or long regimen for 18 to 20 months, which these drugs have been started, he did another type of drugs. As a patient result, patient developed hallucination, restlessness, and also hypothyroidism. This both the symptoms might be due to the ADR of the ETO. This is what have been shown here. It is not sure, but as per the history and since there are no other issues regarding depression and hypothyroidism, so we assume that it is due to ADR of ethanamide. So he was prescribed haloperidol, clofazimine, propanol, and other drugs along with thyroxine 25 grams. Just a minute. Now, if the regimen was not, this is the regimen which was shown by another private practitioner who was untrained, and see what he did. These are the regimen which he did permutation combinations based on the X-ray of 10th March, 10th June, and 19th August. And sir, just a minute, problem aa rahi hai meri paas. Sir, slide is not moving. Now here, though you see in all the 3 X-rays, there is no major change, but medicines were changed repetitively. From March to June, you're saying that's almost the same thing. But see, the regimen were orderly changed. Sometimes ethomidol was added, sometimes rifampicin and amikacin were withdrawn, and sometimes clofazimine, this were added. Now here also, you are seeing in August, slightly because of the increased opacities in the right upper zone continuously for last 3 years, there was starting a slight fibrosis, and you see the trachea started shifting on the right side. So outcome in 3 years was what? These are the outcomes. He went to a private lab. It was, I don't know whether it was accredited or not. So here, this is the thing that all the drugs are resistant as only ethanolamide and PAS is sensitive. Now, as per the history, when the patient went to Prayagraj, these are the drugs which were given. Regarding cycloserine, it was an issue. As Dr. Amitabh has rightly mentioned, it might be a cause of psychosis, and since the patient was consulted with a psychiatrist, he said that it can be given, but close monitoring can be done. So clofazimine was replaced by PAS, Delamid was given, and the pyridoxine was also given. The treatment strategy, as has been mentioned, was bedaquiline given, okay. Tablet linezolid were not given because he did not take it previously. Tablet moxiflox or linezolid was not given because second-hand LPA showed resistance, and patient has also taken high dose of moxifloxacin. Cycloserine, as I've already said, depending upon the with the consultation of the psychiatrist, that close monitoring should be done, weekly monitoring should be done, so it is given. Clofazimine was replaced by PAS. I don't know what was the reason. And this FAQ was replaced by Delamid. Ethanolamide was not given because of the patient might be in depression in taking the antidepressants. Just a minute, sir. So the query was regarding WGS patient. Now patient is sensitive as per the, if we see the reports. Now in group A, bedaquiline and linezolid can be given. Clofazimine not given. I don't know what the reason. And in that report also, psychosis status is not mentioned. But as per the expert opinion of a psychiatrist, it can be done. Delamid can be given. It's still not in the December. Injection amikacin is sensitive in this report, but in resistant was in previous report. And ethominoid was not given, maybe due to depression, and PAS was given. Now the updated status is that what sir is giving, linezolid, cycloserine, PAS, pyrazinamide, along with bedaquiline and Delamid were given, and they were stopped in June. Now the follow-up report, as you are saying, that sputum culture is negative on 24th, sputum culture is negative again on 25th, and patient has gained also, and in last 9 months, and he's on treatment. And patient is improvement in terms of clinical, radiological, and immunological assessment. So I personally talked to the patient yesterday, and he said, "Sir, I am okay, and but I am also taking the drugs of antidepressant. Measure you take it. There is no issue." And this is the regimen which has been given. You are seeing this, how the regimen has to be designed, and I will appreciate Dr. Amitabh Das Shukla that he has done the exactly thing which is required in the current scenario. And we have to, although apart from this since the treatment has to be done for 18 to 20 months. So the follow-up monitoring has to be done till the end of the treatment. And also after 2 years, I would say the DTO Prayagraj is also there. I would have advised him to continue follow him and his family members also till 2 years. Now, the main thing is that since the patient has suffered a mental trauma regarding this all problem, so palliative care is also should be given in terms of neutral support like Nikshamitra, continuation of ancillary drugs for depression, hypothyroidism, which is already taking, psychological support, respect for patients' belief and values, and regular medical visits should also be there from the NTP staff. If it is done, then patient will definitely be cured and become healthy. Just a minute. This is my last slide, sir. I would say thank you for giving the privilege of UP in presenting such a case in a difficult to treat clinic at a national level.
Thank you, sir. It was
Thank you.
it has clarified many of the doubts. Now we can go to Dr. Vishal and take his opinion on this case, who is our national expert for today's clinic. Dr. Vishal, sir.
Dr. Vishal, you are muted, please. Please unmute.
Yeah. So I think first I must congratulate all the STO as well as the Dr. Amitabh as well for presenting this case. मुझे जो सर ने बोला, डॉक्टर राजेंद्र प्रसाद ने, I think it's the unfortunately the misuse of the drugs, the failure of the system, and also a part of our program. My first question is that on the third slide, was the patient put on, when he was put on ATT on 20th February 2019 under NTEP, was he given DOTS? Though he was sputum negative, did we do anything extra to do to get the sputum positivity done, microbiological confirmation? I think it was not done. Dr. Amitabh, could you comment on that, please?
No, sir. Initially, the patient was not a sputum positive. When
तो वो आपके पास आया था कि कहीं और था वो?
नहीं, वो कहीं और था सर. दूसरे प्रैक्टिशनर से वो ट्रीटमेंट ले रहा था, and that it was out of DOTS. It was not even an NTP.
अच्छा, यहाँ पे लिखा है under NTP लिखा है, वो started under NTP. Anyways, so he could have been primary drug resistance at that time, maybe because we might have missed. Dusra was that after then he took treatment, and though I assume that उसके बाद IP phase के बाद भी उसका sputum examination नहीं हुआ. Was it correct in 2019?
The record's not available, sir.
Yeah, record was not available. So interestingly, उसका CP phase के बाद it was the sputum was positive and the patient was found to be rifampicin resistant in October 2019.
Yes, sir.
So here I was saying, जो sir बोल रहे थे कि education of the private practitioner तो है ही, but here it was the failure of the system as well as that there was no record of IP done for the sputum after the intensive phase. तीसरा मेरा ये question था कि that जब once the patient had stopped taking regime, did anybody visit? Can the STO make a comment on that? That did anybody, because he was a police personnel, though we cannot leak his I mean we cannot tell his identity, but did anybody go to him and tell him that why have you stopped taking drugs?
So since the patient, as per the what I've been in the history is that he's he was in police and he had to go in various districts also, and there are such orders that they cannot deny such orders in spite of being ill health. So because of these issues, he had to visit frequently, and there might be the result that he was not able, when he had gone to some other district, there he was not able to assess what are the conditions there and where is the primary health facility.
That's
where
right.
I should go.
That's right.
Yeah.
So my humble submission to everybody here is specifically to UP and to us as well. If we take it as an index case, can we make some kind of a presentation for the program that the persons who are in transferable jobs can be given some kind of a liberty, or they come under the program again?
Sir, they have already the Nikshay ID. With the Nikshay ID, if they can show to any health facility across the India, I would say, then they will be already converted. Already they will be informed. Sir,
वो मैं समझ रहा हूँ, पर वो किया नहीं ना उन्होंने. So कुछ ऐसा कर सकते हैं कि ऐसे problems हमें ना आए आगे से. We'll discuss. एक मेरा question था, then that was slide number 6. On 27 September 2019, second line LPA was sent, but report received in November 2019. The fluoroquinolone resistance, was there any kind of mutations which was shown in this? Any mutations?
So
Because he was switched over to high dose moxifloxacin.
They were not mentioned, sir. It was only that FQ resistant was mentioned. Mutations were not mentioned, sir.
Okay. ठीक है. So बाकी सर आप एक बार स्टार्ट कर लें रूपक सर. बाकी जैसे आएगा I'll keep on asking questions, sir.
Okay, thank you, sir.
बाकी I think this is all oral longer regime should have started. मेरा एक last question आपसे ये है that now that though the patient has improved and the patient has increased by 1.5 kgs, weight भी increase हो गया है, but do you still feel that bedaquiline should not be extended? Because we have a very poor regime of linezolid being the only bactericidal. Rest all are not very strong drugs. Any comments on that?
Sir, it depends upon the as per to my knowledge, it depends upon, since 2 cultures have already been negative and patient is improving. So we have to do close monitoring till since now only 6 months have passed and still 1 year is left as per the longer oral regimen. So we have to wait till 1 year and we have to do after quarterly monitoring also. And if anyone positive found, then we have to do monthly monitoring. So this is what we have said to the DTU also, that the monitoring of this patient and all types of such patients should be done very rigorously and very close monitoring should be done, sir.
No, sir. My only concern here is that because we are having just 3 drugs, और अगर आप कल्चर के बाद कुछ ऐसी रेजिस्टेंस आ जाएगी तो यू विल नॉट बी लेफ्ट विद एनी ड्रग्स. सर ये मैं सर डॉक्टर रूपक से पूछना चाहता हूँ सर कि व्हाट आर योर कमेंट्स ऑन दिस?
Yeah, Dr. Vishal, I'll request Dr. Ritu to give her comments about the WGS. Then I'll be taking the entire case for my comment. You have raised a very genuine concern, which even I have. So after Ritu, I'll be taking my comment. So Dr. Ritu, please be brief and whatever you want to say, please.
Dr. Ritu, are you there?
Okay, till Dr. Ritu joins, you see, I would like to take the case from the beginning, as Dr. Vishal and Dr. Rishi has also mentioned. First of all, the non-compliance has been discussed a lot, and it is the duty of the program also, besides the patient.
Sorry, sir. Actually, I wasn't muted. I was muted earlier, so I could not speak. It's just been on. So if you want, you could just complete, sir. I'll go after you.
No. Please complete, then I'll start.
Yeah, so I just wanted to make one comment that there was a discussion between WGS and midget culture. So for difficult to treat cases, and if we are not able to find solution, I wanted to really highlight this. Though midget had been a gold standard, there are times that in some cases it may give possibly some kind of a false positive or a false negative result because the breakpoints are not always established, and that may be clinically irrelevant. So especially for first line and second line drugs, for PAS, clofazimine, even pyrazinamide and all, in case we do have a WGS report in front of us, and as per WHO mutation catalog, which is available on the website, if it is clinically highly associated with mutations, and let us say it's showing sensitive on your midget, one should consider WGS in the cases where you are not able to arrive at a proper regimen. That's all I wanted to say.
You see, Dr. Ritu, in this national forum, what you have said is technically very correct. But in this national forum, we want to give a clear message to the attendees that as of today, the WGS has not been accepted by the program to take clinical decisions.
Yes.
That is a reality. But technically speaking, as you said, it's a technique which can be used, especially in cases where you don't have midget report. You are relying on the clinical history of the drug intake and the response to the treatment. Plus, you have the WGS report. You can take the help of this report in taking the call whether what to give to the patient, what not to give to the patient.
Sir,
Yeah.
Sir, I have a query regarding this because the genomic sequencing of its WGS is basically based on the citizens of UK. What I have got the information, and still Indian patients genome sequencing has not been done. So the report which is coming, it might be due to the genomic sequencing of the UK based patients.
No, sir. Sir, that is little partly correct. I'm just want to clarify this. The message given here is not that we should do WGS in all cases, but in very, very few cases where you are just not able to come because it is anyways, as sir rightly said, it's not supported by the guidelines. But जैसे होता है ना सर कि हम एक लास्ट केस में एक वो ड्रग देते हैं जिसपे ट्रायल चल रहा है या वैक्सीन देते हैं even if knowing कि it may not work. Similarly, it's like a technique diagnostic which may consider in a desperate situation, and in case you're not able to come to a conclusion or make a regimen based on MIGIC report. Only then, but in sync with the WHO mutation catalog manual, and only if it is high probability with resistance. Only then. Otherwise, you may not consider it, sir. And definitely the data is based on international evidence as of now, but it does have few Indian studies also. And बहुत ज़्यादा फर्क नहीं होना चाहिए. Indian catalog will be also coming shortly.
Okay, thank you, Dr. Ritu. So coming back to the case again, so the issue of compliance has to be there to be considered, and as discussed, even if the patient has a police duty and is going from one district to another district, program has clear guidelines and availability that if a Nikshay ID is there, if a patient wants, he can go to any nearby clinic, and there the treatment can be given. And the concerned DTO of the original district can communicate with the new district where patient is going to give medicine to the patient. Second thing is, even Dr. Vishal raised this point. You see, initially, we don't know whether patient was primary resistant from the beginning. He was put on smear negative, but we could have got the culture done in such cases. You see, we have to follow universal DST guidelines. So as far as possible, whenever we are diagnosing a case of TB, whether smear positive or smear negative, it is our duty today to try to ensure the DST pattern of the patient. In case we know that within 2-3 months that okay, culture is positive and the LP or the gene expert on the culture is saying so, we could have given the appropriate regimen to the patient, and maybe this issue of drug resistance could have been avoided. Third thing is, which is very important, I have been raising this in many forums. In September 19, he was given the injection-based shorter regimen. Okay, that time, 2019, it was there. The second NLP was sent, and the report came after 2 months. You see, whenever we are starting the shorter regimen, it is our duty to try our best to have the LP report as soon as possible. Otherwise, like in this case, it happened after 2 months, we come to know that he is fluoroquinolone resistant. So that means for these 2 months, he was on a wrong regimen. For these 2 months, he was on a regimen where we could have got the other drugs like kanamycin, clofazimine, which are there as a part of the regimen, that they will also become resistant to this patient. And currently, we in the country, we have bedaquiline-based shorter regimen. So in case we give it to the shorter regimen to a patient who is fluoroquinolone resistant, say for 2 months, we will lose bedaquiline, we will lose clofazimine also, and of course, the fluoroquinolone is resistant. So out of the 3 important drugs of the 5 drugs in the all or longer regimen, already resistance will be there. Plus, as somebody mentioned in the chat box also, clearly this case had bilateral disease, so it falls in the extensive disease. There was doubtful cavity also. So this was a patient where the shorter regimen was contraindicated. So we have to take into account whenever we diagnose a case of resistance or MDR-TB, there are indications, there are contraindications. So the indication is rifampicin resistance, or there is MDR, but there should not be resistance to both the mutations of INH, that is INHA and CATG. There should not be fluoroquinolone resistance. There should not be severe extensive pulmonary disease. There should not be severe extrapulmonary disease like you have the CNS TB, miliary TB, meningeal TB. Patient should not have taken more than 1 month of fluoroquinolone, clofazimine or ethionamide unless you have documented sensitivity to that. So we need to see these things before we decide that in this case of rifampicin resistance, I can give shorter regimen. Otherwise, In case any of the contraindications are there, we have to switch to the longer oral regimen to this patient. So very important. And then you see in the shorter oral regimen, it is very clear, it clearly mentioned and logical also that as of today, as per the current evidence, no modification, permanent modification is required. In case due to any reason, intolerance or resistance, we have to stop on drug, we need to shift to the all oral longer regimen. In this case, the FQ was resistant, low dose maybe, but shifting to a high dose moxifloxacin was not a good choice at all, and even the INH was stopped. So that means we have altered the entire regimen of the shorter regimen. And let me tell you, we have discussed this in the earlier discussions also. The LPA for the moxifloxacin is not very reliable. Even the LPA manual says whenever there is a moxifloxacin resistance on LPA or the levofloxacin resistance on LPA, it must be confirmed by the culture and DST. And also as per the data received by I was a part of that committee which the scientific division had called the clinician as well as the microbiologist, where we were seeing the concordance between the LP report of levofloxacin or moxifloxacin resistance and the major culture and DST, which is definitely more reliable. That even if the LPA says moxi low dose is sensitive, is resistant, but high dose is sensitive, in almost 30, 40, 50% of patients, the major culture reported it was resistant. So never rely only on the LPA. You may take an initial call, but must review as soon as possible. The culture DST report is available, and we should not modify the shorter oral regimen from levo or to the low dose moxi to high dose moxi in case there is a levo resistance. If levo resistance is there, please do not give shorter regimen. Then between June 22, patient received multiple regimens. Again, we have to, Dr. Rajendra Prasad already mentioned, we have to educate our colleagues. We have to have the CMEs in every state, wherein we need to tell our colleagues that what is ideal regimen, what is not ideal regimen. We should not add single drug or two drugs to a failing regimen. And only then we can prevent the augmentation of resistance. Then in over 22, the immediate DST showed resistance to all except ethionamide and PAS. But patient had received ethionamide, if you see before this, number of times. Even clofazimine had been received for 2, 3, 4 months before the patient reached the Prayagraj. And accordingly, being a medical college, being a senior experienced faculty, Dr. Mitab Shukla and his team decided not to give, in this case, the ethionamide as well as not to, although it was said to be sensitive by this, but it had been used multiple times in different poor combinations. So even the clofazimine they did not give. Now coming to the current regimen, which patient was put on in the month of December 2022, patient was put on a regimen from group A, bedaquiline and linezolid. From group 2, the clofazimine was dropped because he had been taking that in the last few months. Cycloserine, and from group 3 to make 5 drugs, delamanid and PAS was picked up, which was a very good choice under the circumstances. So you have bactericidal drugs, you have group A drug, group B drug, and group C drug. Now the only issue is, as Dr. Alpa has also raised in her comments, Dr. Vishal has also raised in his comment, that once the 6 months are over, even if the patient is responding clinically, radiologically, and microbiologically, we should have a good continuation phase. Secondly, you see, cycloserine in this case, once you stop bedaquiline and delamanid after 6 months, we are left with linezolid, cycloserine, and PAS. We all know cycloserine is a drug which can cause psychosis, depression, and this case was already a known case of whether drug induced or not, we are not sure, known case of psychosis and depression, and he was on medication for that. So we cannot rely that we will be able to give this drug for next 12 months. Anytime in case the psychosis or depression increases, we may have to stop the cycloserine. Then again, we will not know what to do. Even linezolid, you see, all of you must have seen the side effect of linezolid, especially peripheral neuropathy, is quite common. Maybe 20, 30, 40% of the patient may have this. So in the continuation phase, in case patient develops significant grade 2 or 3 peripheral neuropathy or some other side effect of linezolid like anemia or optic neuritis, we may have to stop it. So plus, if you see the basic principle of a good continuation phase is, I was a part of that guideline in the Central TV division when we were deciding about the initial intensive phase and continuation phase in the all or longer regimen, the continuation phase should have preferably 2 group A drugs and 1 group B, or 1 group A, 2 group B accompanied by a 4th drug. That will be an ideal continuation phase. So in this case, in the continuation phase, we will have linezolid. From group B, we will have cycloserine. So we need 3rd drug. Totally we need the 4th drug. So linezolid, cycloserine, PAS are only 3. We need to have 4th drug, which otherwise, looking at the background and the visit report, we do not have. So in this case, ideally speaking, bedaquiline should be continued throughout the treatment. So we should have a continuation phase consisting of bedaquiline, linezolid, cycloserine, and PAS, so that even if we have to stop one of these drugs due to various reasons, we may have a reasonably good continuation phase. And if you really ask me, I don't mind continuing delaminate for the first 6 months of continuation phase. And then after that, in case patient is doing well, we can drop delaminate and continue with bedaquiline, linezolid, cycloserine, and PAS. Because we need a good continuation phase for this patient. And let me tell you this, whatever regime we make for this patient now, this will be the last regimen for the patient. We do not have other drugs. Only drug which is left is the imipenem. And you know the logistic issues with imipenem, the cost, we need a PICC line, we need an infusion 1 hour in the morning, 1 hour in the evening. So practically under the programmatic conditions, we are not able to use the imipenem. And most of the patients will not be able to afford this. 2,000 per day for imipenem for 6 to 8 months. Then cost of putting the PICC line is around 18 to 20,000 at least in Delhi. So programmatically, it is difficult to use imipenem. So I suggest in this case, in the continuation phase, we should have 4 drugs: bedaquiline, linezolid, cycloserine, and PAS, and closely monitor for the known side effects of these drugs. Like we know for linezolid, we need to do the CBCs very regularly. We need to ask the patient about any peripheral neuropathy symptoms. For cycloserine, already patient is on the antipsychotic drugs, so we have to take care of that. And also, I want to highlight here that among the antipsychotic drugs, among the risperidone is said to be safe with bedaquiline. Once we consider the patient is on bedaquiline, we have to keep in mind the interaction. The antipsychotic drugs like haloperidol, then olanzapine, clobazapine, they are to be avoided in case of the bedaquiline. Similarly, among the antidepressants, they say best is to avoid antidepressants. Most of the antidepressants will have interaction with bedaquiline. And even the fluoxetine, the citalopram, the sertraline, which are the common antidepressants, they're also not safe to be given with bedaquiline. So we have to keep in mind that aspect also. And WGS we've already discussed. That was another issue in this case. Dr. Ritu has informed us about the status of the WGS. So that's all from my side, please. Thank you all. In case you have any comment, you're most welcome.
Thank you so much for the elaborative discussion and explanations of in detail. I request each one of you please see the chat box, and we have floated the feedback link there, and kindly give your valuable feedback so that we can improve our sessions further. It's there in the chat box. The link is there in the chat box.
Sir, may I ask a question?
Yes, Dr. Vishal.
Sir, now that they have stopped bedaquiline since 1/6/2023, so is it wise to add it again now?
Yeah, it's a very important question you have asked. I don't mind, frankly.
Even I don't mind.
Because these 3 drugs are not a very good continuation phase, especially when in case due to any reason, a side effect or so, we have to stop, then we'll be in a loop. So better
I would, if you suggest, we can suggest them that again, your comment that I would not even mind to add delaminate and bedaquiline both again. Because I feel that we will, again, same your comment, we will not be left with anything else to treat him later on.
So we can do that. We can add BDQ and delaminate for 6 months. And then after that, we can stop delaminate and continue with the 4 drugs, including bedaquiline. That can be done. I leave it to the UP state
yes.
whether delaminate is available or not. If there is issues of availability of delaminate, things are different. Ideally, patient should be on bedaquiline, denamide, linezolid, cyclosporine, and PAS. Even PAS is difficult to tolerate. You never know when patient starts saying that I'm not able to, and sometimes they're not even taking, especially such patients who are non-compliant. You see, in the olden times, we were told that in the TB hospitals, all the gardens around the window, they were pink. Because none of the patient used to take PAS. It's such a bad taste. I remember I'm going for the round. Patient told me, Doctor साहब बहुत आसान है कहना खा लो कभी आपने खा के देखा एक चम्मच भी तब पता चलता है कितना इसका बड़ा टेस्ट होता है. And especially such non-compliant patients.
Sir, regarding if we want to recontinue the bedaquiline, can we do prior bedaquiline test, sensitivity test at at your hospital, sir?
No need. You see, because that will take another 2 months, maybe 3 months. So we should not lose this. Simultaneously, we can now this patient is put on smear and culture negative. So that may not help us at this stage. At this stage, sending a sample for culture and DST not only will take time, and maybe culture will be negative. So better we take a call and we start. And as we discussed, we should go like that. That is my suggestion.
Okay, sir. Thank you.
Thank you.
Thank you very much, sir.
Thank you, Dr. Vishal.
Thank you.
And thank you, Dr. Rishi, also that you picked up a very good case from the UP state. And Dr. Mitav, of course, he not only picked up a good case, but he presented very well. So that all the important questions, you see, we want to pick up the case as Dr. Joshi also mentioned in the we can pick up the issues which are there. So this case has focused on many issues. So that is the aim of our this difficult to treat TB clinic, that we raise the issues and we look for solution. And whenever we are asking other states, we request them also to pick up such good cases wherein we can.
And sir, we should also focus on the palliative care also, because here when I yesterday discussed with the counsel, the patient also, he was in a state I had told us, see what you are doing. I just counseled the patient and his mood was sometimes elevated. So this part of palliative care is also important as with counseling also. Palliative care should also go side by side, sir. This is what I've experienced, sir.
Okay, thank you, Dr. Rishi. Thank you, Dr. Vishal, Dr. Mitav, all of you. We thank from the bottom of our heart.
Thank you, sir. Thank you, sir.
With this, we end our session, today's session. Thank you very much, each one of you. Thank you. Please do give your feedback before closing it. It's very important to continue this session. Your feedback is very important to us. Thank you. So to fill the feedback, we'll be running it for 1 more minute. Please click on the feedback link and give your valuable feedback to us. It's in the chat box. The feedback link is in the chat box.